Thanks everyone for being in our symposium on new technologies for OCD monitoring and treatment. The rationale for this symposium is because obsessive compulsive disorder, or OCD, is a very serious disorder that is characterized by intrusive thoughts or obsessions and repetitive behaviors or compulsions that patients usually undergo to overcome the obsessions. Um, the symptoms may consume many hours per day, like from 4 to 12 hours a day, and definitely impairs the overall quality of life of patients and affects 1 to 3% of the world population. When we think about 1 to 3%, we think, oh, this may not be that common, but it's actually very important for those who were affected by it, especially because OCD may lead to increased risk of suicide, with 1 every 10 patients already attempting suicide over their lifetime, and 1/3 of the patients having current suicide ideation. So it's very important for us to have very reliable diagnosis methods, having very reliable treatment measurements, treatment follow-up systems that could help clinicians and patients to improve their quality of life. Um, and of course, I forgot the last line, which is basically mentioning that half of the patients have already had suicide ideation in the past. So in our panel, I'm Lucas, and Jamie will be supporting our panel here, helping managing questions and answers and the discussion. And we do have the first presentation, which is going to be done by Dr. Moreira-neto on how we can use functional near-infrared spectroscopy as a potential imaging tool to evaluate symptom dimensions in OCD. We have the second panel that is going to be presented by Master Zhang on early identification of non-adherence of ERP therapy using machine learning and real-world digital phenotypings. And the last presentation is going to be presented by Master Zhang on neurofeedback interventions for OCD, presenting a general overview of the current level of clinical evidence, the technology, the advances in the technology, and the next steps for real-world implementation of this. So without further ado, I wanted to give the stage to Acácio, who I'm not sure if he just should start presenting. Dr. Moreira-neto has a PhD in physical education and also a degree in pedagogy. He's currently a postdoctoral fellow in the University of Sao Paulo and the Institute of Psychiatry, and in the largest OCD group back there in Brazil. And please, the stage is yours, Dr. Moreira-neto.
Hi, everyone. Thank you for the opportunity to share our results and research with you. My name is Acácio Moreira, as Lucas said, and I'm member of ProTalk, a group that study OCD about 30 years. So today I'm going to share some results about our project using fNIRS, functional near infrared spectroscopy, uh, measuring prefrontal cortex activity in response to aversive image in people with OCD. So this is a guide for our presentation. OCD is one of the most mental disorder, knowledge mental disorder, and has some specifically dimensions that are contamination, unrelated, unceptality symptoms, and symmetry symptoms, and is characterized by obsessions and compulsions that could reduce quality of life of those people. So one of the main mechanisms can explain alterations in OCD are prefrontal cortex alteration and dysfunction. So in this study in 2004, they found that watching, checking, and specific dimensions in OCD could change different brain regions, and especially in prefrontal cortex. To measure brain activity, we have a lot of tools like EEG and fMRI. It's one of the most knowledge measures of the brain. And we also have fNIRS. And what's the benefits and different of NIRS? So uh, they have the NIRS have the same measure of MRI that it's both signal, it's accessibility, portable and expensive, easy to set up compared to MRI, had less noise, anxiety, don't have the anxiety as you had the MRI. You can use using magnetic implants and head movement. And NIRS measure brain activity using infrared signal. So the aim of our study is determine exposure to CDE is related to aversive images induced change in prefrontal cortex and identify predictors of clinical alterations due to experiment. So we have 17 individuals with OCD, and we measure uh, we measure the OCD insights in depression symptoms using iBox and Hamilton scales. And we also use visual analog mode scale to understand emotional response right before and after our protocol showing aversive images. We have committee approbation, HK committee approbation, and we use our database of aversive images for OCD, not exactly aversive images at all. It's specifically images of checking, organization, and cleaning for OCD people, and we people with OCD, and we also use neutral images. Uh, we use a normal utility, Shapiro-Wilk, to understand if data is normal, and t-test and Wilcox, depending on the normality of data. And we use stepwise regression to identify the main predictors of clinical measures. We process fNIRS images using Homer 2. So this is the positioning of optodes. And I brought a video to explain better the protocol that we use it. Let me. Uh, so here you can see the video. So the volunteer can see the NIRS. It's very small, as we can see here. And this is brain activation provided by NIRS. And here we can see in the screen the aversive images or neutral images that volunteer needed to score how much it's aversive to those images. So the images we show it like 5 images in each cluster, and after that they need to score how much was aversive, and then another cluster of images was um, passing through the screen. So uh, as I said, we have 17 volunteers. Most are female, aged 40 years old, 30 educational level, and even OCD symptoms and anxiety depression symptoms are relevant. So we observed that 57% of severity OCD symptoms could be explained during the cleaning, the contamination dimension of OCD images in the right prefrontal cortex. And we also observed the same predictor in anxiety symptoms. It's explaining 40% of the model. However, the middle frontal gyrol also entered the anxiety model, explaining during the cleaning and checking, explained 26% of the model and 12% of the model. So one interesting results that we saw is that the protocol is safe, and the people who made the protocol don't have emotional significant changes, so they can solve the aversive images and they can come back home. This is individual analysis of some people that make the protocol, and we can see the neutral image, it's blue, is less aversive compared to checking, symmetry, and washing images. We concluded that NIRS could be used to monitor prefrontal cortex activity during the images, aversive images for OCD. And NIRS also have a potential uh, tool to therapies such as neurofeedback and adjunctive treatment for OCD. And one of the reasons we are tested that aversive images database and using NIRS to observe it prefrontal cortex activation is that we are making neurofeedback protocol, as we can see. So that's one of aversive image for OCD, and we can see the autoregulation of prefrontal cortex during neurofeedback. It's the main project that we are doing. It's changed by the saturation of the image. So we can see the image became black and white and more colored, and we are instructing the volunteer to try to auto-regulate the prefrontal cortex to remain the image as the natural, as neutral color. And this is our reference. And thank you very much for the opportunity to share our research with you and our group, ProTalk, FAPESP, that has the grant number. And UFABC, it's another university of Brazil that are helping us, and also Lucas here. Thank you very much.
Thank you, Acácio. Great presentation. Our second panelist is, wait, am I muted? No. Our second panelist is Xuying Zhang. She has a master's in statistics and is currently a PhD student at the University of Illinois Urbana-Champaign, and also a research associate at NOCD. With that introduction, I would like to give you the stage, Xuying. Thank you.
Yeah, thank you so much for having me here. A little bit more about me. So myself has lived OCD experiences for more than 10 years, and I got treated at NOCD, and it greatly changed my life. Later, I developed an interest in researching and advocating, and I joined NOCD. I will be presenting on our machine learning prediction project of therapy adherence for OCD using baseline and early stage treatment data today. Why is OCD so important? So first, this is not a rare condition. The lifetime prevalence of OCD is 1 to 4.1%, and 12 months prevalence is 1 to 3%. It means at any given time, there are millions of people affected by OCD. OCD can cause substantial functional impairment and reduce the quality of life. The patients can be really struggling with their work, school, and relationships. If remain untreated, the OCD can be a chronic cause lasting for years. and causing high burden for both the patients and their families. That's why we need further precision medicine and therapy to allocate the scarce resources to relieve the patient's burden. Currently, the exposure and response prevention therapy is the golden standard and first-line treatment for OCD. Most individuals with OCD can benefit from ERP. However, although this treatment is very effective, it requires the adherence of the patients, which means the patients need to accomplish a certain amount of sessions and homeworks. The adherence is not only a key determinant of the ERP effectiveness, but is also a strong predictor of the post-treatment improvement. The early phase of the therapy is critical. If we can identify which patients are at risk of early dropout, and we can intervene and support them before they disengage. And
this sorry to interrupt you. Can you share your screen so we can see your slides?
Oh, it's not shared.
Yeah.
Oh, sorry, I was not aware of that.
It's okay. You're.
Can you see my slide now?
I can see it now. Yeah.
Not on presenter view.
Nope, it's regular slideshow.
Okay, good. Yeah. Okay. So I was at if we can identify which patients are at risk of early dropout, and we can intervene, and this will eventually help them to gain better therapy outcome. However, the measurement and predicting of adherence can be challenging because we need to collect not only the adherence data itself, but also the adherence-related metrics, and we needed to identify the markers that can be used as potential indicators of adherence at the early stage of treatment. In a traditional outpatient ERP, it can be hard because the data collection relied on the on-site visit of the patients and the proactive lay records made by the therapists. Here, we are addressing this problem by using our video-delivered ERP platform and NOCD. NOCD is world's leading OCD treatment provider. We provide ERP by therapists we train on a rigorous and standardized training and certification program. Currently, we are having 30,000 new patients per year, which enables us to have one of the largest naturalistic OCD therapy data sets. Our digital platform enables us to build sophisticated profiles for both the patients and the therapists and tracking the patient progress on a regular basis. In our parallel work, we built a primary model to predict the adherence. We selected 49 features based on clinical expertise, including demographic, psychometric, therapist-related data. Then we used a logistic regression model trained on 10,000 patients and tested in a holdout sample of 3,487 patients, and which reached an accuracy of 0.65. Then we flagged the patients risky. Then we contacted part of them within peer support intervention. Then we track these therapy outcomes in a 60 days track. Then by peer intervention, we have member advocates who are the peer support specialists who have lived OCD experiences. Then we found that the patients have the risk of dropping out who receive the peer support. Both their hours of completed sessions and their DOC score reduction after the treatment was significantly improved. Currently, we are focusing on building a more precise and actionable model. We are combining 3 sets of features, which are the baseline features of the patient, baseline features of the therapist, and the patient performance and the behavior data up to the 3rd week after their first session. Then we are evaluating the adherence on the 17th week after the patient's first session. Our training set is constantly updated, collected since the beginning of 2023. So currently, it's more than 34,000 entries. And we, to make sure the patients' profiles are complete, we're using the patients who had their first appointment more than 13 weeks ago. And we are currently not including the patients who had a record of a break. For the adherence classification, we classified the patients who attended the 12 or more sessions by their 17th week. as adherent, and the patients who had fewer than 12 sessions by their 17th week as non-adherent. Our prediction set is also constantly updated and constantly under action. We are retrieving about 1,000 new patients per week. Although we have great peer support resources, there are always more patients need help. So we are focusing on the patients who are most likely to benefit from the intervention, which are the patients whose first appointment date within the last 13 weeks, last appointment date within the last 2 weeks, and they are not currently actively engaged in chat with their therapists, and they have total complete appointments between 3 and 6 so far, and they are actively subscribed. We use that data-driven feature engineering approach. We collected 74 features for the demographic, psychometric, and behavioral data of the patients. Then we had 56 features for the clinician evaluation features. Then we have 16 features based on the patient's clinician interaction. Then after we screened for bias, we added 2 interaction features before we reached the model finalization. Our patients features including OCD subtype, the patient demographics, something like billing plan, if the patient is using insurance or cash, and clinical scores, such as DAS scores, DOX scores. These scores are both for baseline, which is the first session performance, and the progressively scores on a weekly basis recording. We also have engagement items such as number of apps opens before and after therapy, chats with therapists, time of clinical form completion, and times of giving ratings, etc. For the therapist features, we have something like administrative features, therapist background, and we have therapist's patient profile, which including features like how many accomplished patients a therapist have had for different treatment milestones, and how many patients are recently rescheduling, which is both accumulative and for the most recent week, so time utilization of the therapists. Then we also use the natural language processing model to mine the interaction flags between the patient and the therapist. We found that the patients have concerns such as if they have asked the scheduling questions or therapist-related questions, therapy process questions, etc. We did a comparison between different algorithms and different feature sets, and most of our models reached a prediction accuracy between 0.7 and 0.8. An important thing we found in this study is the features of early patient engagement are as important as baseline features. In previous similar studies, mostly only the baseline data was investigated. But in this study, we also addressed the early engagement and behavioral data of the patients. In this figure, the x-axis is the importance score of the features. Y-axis are some of the top 20 features. And we can see the top 3 features are the total number of visits of the patient by week 3, total number of diamond form completion, and total number of ratings made by the patient in week 3, which are all early engagement data. We can also see some therapist related data also at the top of this figure. Then we looked into this. For the clinician features, we found 8 features repeatedly show up in the top ranked features across all the models. One of the most interesting things I would like to show is the number of members who have reached so member is actually patients who have reached the 18th session for the given therapist. So this ranking high is indicating if a patient is assigned to a therapist whose overall caseload has strong adherence, then that patient is also more likely to have good adherence. Then we also found other features that are related to the most recent overall patient scheduling behavior of the therapist, such as the percent of the patients or the therapist stick to the schedule for this week and next week, the percent of patients of the therapist who are scheduled for the upcoming sessions, the percent of patients who have the upcoming sessions for the given therapist, and the reschedule rate, cancellation rate. So here is case. which demonstrate how powerful the model is to reveal the hidden dynamics in features that affect the adherence. So we have the hypothesis here: if too many patients can exhaust the therapies, which eventually lead to the non-adherence. Because in clinical operations, we have heard that therapists talking about if they were assigned with too many patients, it can compromise their time and efforts for each of their patients. Here in this figure, the x-axis is the number of patients who have reached their 18th session for a given therapist. Each point is a therapist. The color is rating. Red dots are the therapists whose most rating is high. Blue dots are therapists whose most recent rating is relatively lower. Then we can, the sharp value, if it's positive, it means the patients of this therapist tend to adhere. If it's negative, means the patients of this therapist tend to drop out. In the intermediate range, we saw some blue points with the negative Shapley value. This forms a hypothesis that if the therapist, they are assigned a certain number of members, and if it's a little bit more, it can cause some exhaustion and causes some compromising in their performance, and which can be associated with patient non-adherence. But it's also interesting to see the therapists on the right side of this figure. These are the most experienced therapists. They are not prone to this effect. So after we identify the risky patients for early dropout, we will be contacting them with our member advocates. So here I am showing you an example of how the interaction between the member advocates and the patients works. So this is actually my own chatting history with my member advocates when I was a patient. So this is the first message I got from my member advocates. And here I'm showing that you can ask very specific questions with our member advocates and get very specific help. So I want to thank you for all of your attention. Thanks my awesome team members, and thanks for the great company I'm working with.
Thank you very much for the wonderful presentation. Our next panelist is Kaixi Zhang. She has a master's degree in sciences and is currently a PhD student in the Institute of Medical Sciences at the University of Toronto. And she's going to be presenting an overview of neurofeedback interventions for OCD. And I would like to invite you to share your screen and your expertise, Kaixi. Thank you.
Oh, hello everyone. Can you hear me?
Yes.
Yes, okay, nice. Perfect. Well, I'm grateful for the opportunity today and good afternoon. And today I will be presenting a summary of our narrative review on neurofeedback interventions for obsessive, compulsive, and related disorders about the advances in technology and the next steps for implementations. Well, to set the stage, obsessive, compulsive, and related disorders, or OCRDs, including OCD, body dysmorphic disorder, and hoarding disorders, those disorders are characterized by persistence, intrusive thoughts, and compulsive behaviors. Well, we can see that on the side, we do have a lot of effective treatments, such as serotonin reuptake inhibitors, cognitive behavioral therapy, and neuromodulation approaches. Well, a substantial proportion of patients, roughly 40 to 60%, either do not respond adequately or experience relapse. Well, this persistent treatment gap has motivated increasingly interest in circuit-level interventions, which bring us to neurofeedback. Neurofeedback is a non-invasive closed-brain training technique, and neurofeedback measures an individual's neural activity, including target regions like ROIs or function connectivity in real time. And this activities is then translated into visual or auditory feedback signals after real-time processing. And across modalities, EEG or MRI, well, the core ideas is the same. Repeated reinforcement of a target that can induce neuroplastic changes, leading to improved self-regulation and potentially symptom reduction. And importantly, neurofeedback offers a personalized and circuit-level approach, which makes it particularly appealing for disorders like OCD that are not well explained by single regional analysis. OCD is increasingly understood as a disorder of distributed circuit dysfunction rather than a single brain region. And models on the slide here, we can see that highlight abnormalities across multiple the cortical striatal thalamocortical CFT circuits, including the dorsal cognitive circuit, sensory motor circuit, and the frontal limbic networks. These circuits map onto key symptom dynamics such as habitual behaviors, impaired cognitive control, dysregulated fear, or the intolerance of uncertainty. These circuits provide those research, including the circuits and the impairment, provides a strong theoretical basis for circuit neurofeedback. So we first reviewed EEG-based neurofeedback. This study is favored by high temporal resolution and predictability. A key takeaway from EEG features is that personalization quantitative EEG aim to identify individual electrophysiological abnormalities, such as excessive alpha or beta activity and cellular training. Case series and small files suggest that personalized EEG neurofeedback can lead to clinical, meaningful, and sometimes lasting reduction in OCD symptoms. However, the evidence base is limited by protocol heterogeneity, small sample sizes, and relative poor spatial specificity, which constrains the firm conclusion.
Katie, sorry to interrupt. Your audio is a little bit glitchy. Could you try to turn off your video just to see if it can improve a little bit?
Sorry?
Your audio is a little bit glitchy. Can you turn off can you turn off your video or try a different microphone?
Okay, sorry, first 1 minute. How about right now?
It's still a little bit glitchy.
Can you try headphones?
Yeah, I use the headphones right now. But to reset the Zoom settings.
Sorry, everyone. Nothing like a technology conference with technology issues.
Yeah, I was just about to say that. We're having technology problems for the Technology and Psychiatry conference.
How about right now?
It's much better.
Yeah, it's better so far.
Okay. Well, I hope this can work. So let's continue. Come back to the neurofeedback, and we can see that well, the evidence base is limited by protocol heterogeneity and small sample sizes and relative poor spatial specificity, which constrains firm conclusions. And next, fMRI neurofeedback offers a distinct advantage with high spatial resolution and the ability to target deep cortical and subcortical structures. in OCD, we can see that most fMRI neurofeedback studies have focused on orbital frontal cortex-centered CSTC circuits, which are central to evaluation, error monitoring, and compulsivity. And across this, participants can learn to regulate activity in these regions. Importantly, a double-blind randomized control trial demonstrates a modest but statistically significant reduction in white box scores compared to the sham neurofeedback group. Notably, symptom improvements tended to emerge gradually, suggesting delayed or cumulative effects rather than immediate change. Despite these promising findings, the overall clinical impact of fMRI neurofeedback remains moderate when compared to established treatments. There are also substantial practical barriers. We can see that fMRI neurofeedback is still expensive, technically complex, and requires specialized infrastructure and expertise, which actually limits the scalability. And perhaps the most important thing is current fMRI neurofeedback protocols still struggle to deliver highly individualized representation level precision, which may be necessary for robust clinical translation. And these limitations naturally lead to the question, how can we increase both precision and personalization in neurofeedback? Well, decoding neurofeedback, or DECNAF in short, represents a next generation approach. Instead of targeting average activity in a predefined region, DECNAF uses multivariate pattern analysis to identify and reinforce specificity distributed neural representations. And to explain across views, I first want to briefly introduce functional particularly using hyperalignment. When two otherwise activation patterns are misaligned due to anatomical and functional variability. So now we use hyperalignment, which instead of matching voxel to voxel anatomically, aligns the functional response profiles of groups across participants. And through the process, hyperalignment constructs a shared high-dimension representational space, which we call common space. Each participant's brain data can be transformed from their native space into this common space, where representational geometry is maximally aligned across individuals. And this transformation of on a pattern in the common space, we can project it back into the native space of a specific. And a key advantage of decoding neurofeedback is that learning can occur implicitly. Oneness or strategy use. This feature is particularly relevant for OCRDS, where explicit strategies or exposure-based interventions can be distressing or difficult for some patients. By directly reinforcing target neural representations, DECNAF may bypass some of the barriers associated with the conventional neurofeedback and behavioral therapies. And another exciting direction is motor integration. fMRI can be used to define precise neural targets, while EEG can provide a more scalable and accessible feedback signal by decoding EEG fingerprints that correspond to fMRI patterns. And this approach has the potential to combine the spatial precision of fMRI with the practicality of EEG. Well, at present, it's emphasized that neurofeedback evidence is almost exclusive for OCD. And what I'm showing here at the table is a conceptual hypothesis-driven proposal based on existing circuit model and symptom mechanism in other OCRDS. For example, we can see that in body dysmorphic disorder, distorted cell phase representations suggest a natural fit for representation level feedback. And in hoarding disorder, targeting valuation-related patterns may help bypass the distress associated with discarding. These targets remain speculative and require empirical validation, but they illustrate how decoding neurofeedback feature translation work. So to summarize, neurofeedback shows initial promise for OCD and related disorders, particularly when protocols are personalized. Across EEG and fMRI modalities targeting CSTC circuits, it's the most consistently supported so far. And however, clinical effects remain modest and limited by scalability and also the cost, and also the insufficient precision. And OCRDS are characterized by distributed and idiosyncratic neural representations rather than single region abnormalities. Decoding neurofeedback actually here offers a principled path toward higher precision and personalization by directly targeting these representations. And ultimately, advancing neurofeedback towards clinical translation will likely require integrating circuit models, multivariate representations, and scalable technologies, and which can bring us closer to truly personalized psychiatry. Yeah, that's.
Thanks, everyone. And apologize for the technical difficulties. It was a great presentation, Katie. And I would like to invite Dr. Feusner to moderate the questions and answer session. And I think we may have already some questions.
Excellent. So thank you so much for all the really amazing talks from the panelists and covering a wide variety of different topics. It's very exciting for me to hear these talks, and it kind of covers the new technology that includes digital and hardware applications, and all kind of around the theme of improving our ability to monitor symptoms and then also potentially deliver new types of treatments for OCD. And just to put one thought out there of my own, and then we'll get to the questions, is that I think that one of the themes that runs through all of these is about the idea about personalization. And of course, this is not at all a new concept. But for me, it's very encouraging to see that more and more that the personalization has become, in a way, a de facto way of approaching innovation rather than something that is considered new. It really seems to be applied to more and more different approaches. And all three talks, it was really a part of that. So another thought that I had about these is that something that I would argue is that there's technology that's assisting us in many different ways, but for these examples with OCD and OCD related disorders so far, there is still a role of a human interaction, I should say, to deliver the treatment and or to interpret the results of the data. Since I do think that we still need the clinical knowledge and experience to interpret what's often very large and complex data sets and sometimes the trends of the data sets. And I think a good example of that was the slide that Zheng showed about when you look at the therapists that have a high caseload, that the adherence is really dropping off for those that have less experience or kind of a moderate amount of experience rather than more experience. The therapists that have more experience, then they seem to be able to be able to handle more patients without having as much non-adherence. So I think that type of interpretation of the data, it really comes from understanding therapists' experiences too, as well. But maybe I'll be proven wrong at some point about that. But I think that's kind of where we are right now. So let's turn it over to questions and see if we have questions in the Q&A. And I know that we do have some questions also. Let's see if there's any new questions. Okay. So feel free to ask questions in the Q&A, and you can also feel free to unmute and talk as well. and maybe I'll let some of those roll in. But for now, I do have a couple questions. So one of the questions is from Lucas. And so the question is for Acácio and Kathy. So the question is, with the rise of low-cost wearable fNIRS, for example, Muse or Emotive, would this be a potential tool to accelerate and democratize neurofeedback delivery in underserved communities?
Yeah, thanks for the question. So NIRS is more accessible than MRI. It's less expensive, but it's a new kind, a new um, i- i- it's a new thing to make the neurofeedback. So as Zhang's presentation show that we don't have much studies using NIRS with neurofeedback, so it's everything's new, but it's a specific a machine that could make neurofeedback not only more accessible, but different interventions like compared to EEG. So there's a promising thing that we are working in our group.
Yeah. And also, based on my thoughts, I think fNIRS neurofeedback here actually we can use it as what we plan to combine the EEG neurofeedback and fMRI neurofeedback together. So use the fMRI neurofeedback to new fMRI technique got the decoder were our target pattern there and try to apply the neurofeedback, combine the fNIRS or combine fNIRS and EEG simultaneously and apply to clinical patients to see if the neurofeedback can be helpful.
Great, thank you. So another great question by Lucas is a question. This is a question for Xuying. So what is the acceptance level of these models by therapists who are providing OCD care?
Yeah, this is a great question. So yeah, actually, I wanted to know like acceptance. You mean like what kind of acceptance? Because this is actually a question we haven't asked for our therapists. But later on, we need to definitely ask them to see what's their opinions on these models. And also there are some data usage that we need to invite everyone involved in. Everyone needs to review that. Then for therapist concerns, I guess there are concerns that based on if this model prediction result is consistent with their expertise, if this model is actually helpful for the patients, and if this model is beneficial for their daily work. So I expect there would be all kinds of different concerns from the therapists. So this will be definitely a thing that we will need to later investigate. We need to ask more than a few number of therapists to get the feedbacks and improve the model.
Yeah, something to add that I can add to that as well is that one of the things that is important to be able to in a way explain for therapists to understand is about how the model it has limited accuracy, right? So it's not 100% accurate, and so it's going to have false positives and it's going to have false negatives. But the goal really of it was to develop something that can on a large population level make a difference. And so rather than it being necessarily very accurate for each individual person, this is actually kind of more that on the whole, that there'll be enough people where it's a true positive and the member advocate reaches out, the peer person, and helps them stay in treatment, that it'll make a difference. So that's something that is, it's a concept that not everybody like maybe fully understands about how it's supposed to work.
And I think that like we always emphasize that all of these are adjunct resources, right? They would not like replace anything that already exists. It's just like one additional tool that therapists would have, right?
Yeah.
Yeah.
I have a question now. This is for Kathy. So Kathy, the with the neurofeedback and looking at, you gave some examples of studies and there's different targets. So do you think that the neurofeedback approaches need to target quote unquote dysfunctional regions in OCD? So in other words, regions or circuits that are differently activated, different patterns than healthy controls? Or do you think that there could be other targets that are non-dysfunctional targets? And if so, what types of mechanisms would they need to tap into to be effective?
Well, I think except the STC circuit, except treating the CSTC circuit as the target, there are also are some possibility to set other circuits or other brain activity patterns as the target. Because we know that compared to the healthy control clinical patients, they might not only have the dysfunctional brain activity pattern there, but also like maybe have some compensation related brain activation there. So if we maybe there still is the possibility to select those brain activity pattern as the neurofeedback target and to see if the participants can like decrease their clinical performance just by manipulating the compensations brain activity there. If like to see if this way could be success in the future. Yeah.
Okay. Kathy, because there was some difficulty still with hearing your audio, do you mind typing out that answer? Just in case somebody missed it. All right. Any questions from the audience? Okay, there is another question from Lucas. And the question is still in the context of acceptance for all panelists, what's the acceptance from OCD patients to these new technologies?
So I have a comment about that because when we use NIRS in OCD patients in neurofeedback, they show it great a great experience. Like it's a different kind of treatment that they don't hear about. So we are used to treatments and medication and therapy. And when they see another kind of intervention, maybe could be not only different hope, but specifically adjuvant therapy that could help them.
Great. Zheng, it looked like you were maybe starting to say something.
Yeah, so for my project, we haven't like comprehensively investigated the acceptance of patients. But by my own experience as a patient, I feel this is a very helpful model. And currently, our interaction with patients based on the model is having the member advocates, which are the peer support specialists, contacting them and asking them if they have any concerns and difficulties, and they can give personalized help. And currently, based on our review by the clinicians, like if we contacted some patients who are not the most risky of dropping out once, it would not have too much negative effects. So generally we are we we are expecting that the patient acceptance should be positive, but definitely this will need more testing. And we also we need to take into considerations of data usage authorization of the patients. So yeah, this is my my 2 points on this.
Great. Thank you, Xuying and Acácio. And yeah, those are great questions, very practical questions, because technology can be great and amazing, but if it's not accepted by the people that it's really designed for, then it doesn't really mean a lot. Well, I think we're out of time. So thank you again to all the panelists for really exciting talks, and thanks for the audience for your attention. And hopefully this is something that was useful and interesting to you today.